Hello and welcome to the monthly Henry Schein series, Health Concerns in Dentistry, How to Ensure the Safest Dental Visit. I'm Dr. Gary Severance with Henry Schein, and today is in fact our third anniversary of this series, and Dr. David Reznik has been with us since day one. And by the way, he recently received another honorary award, the Distinguished Alumni Award from Emory University. So let's hope his head still fits on the screen. Today he'll address not only COVID, but also respiratory virus, periodontal links, risk stratification, and much, much more. Welcome, Dr. Reznik, and congratulations on the award.
Thank you, Gary, for that over-the-top introduction. I guess I'll take this opportunity to wish you a happy birthday, as this is your birthday today. And I think everyone on the call should wish him a happy birthday as well. When we start to get older, we need all the encouragement we can get. So with that being said, let's go into some health concerns in dentistry. And part of what I want to focus on is on the medical-dental interaction and where we are and how we can improve our patients' outcomes by working together. I think that is truly one of the most important things that we're seeing. It happens in some duly located, fairly qualified health centers where medical and dental are in the same building. I've had a blessed career where I have worked in HIV disease, and we have Center for Wellbeing. We've got a women, family, children program, a primary program, medication assistance program, peer navigators, etc. So I have grown up in an environment where if I see a problem, I can directly go to the primary care provider. If they have an issue, they can directly either message me, call me, or literally come up to the oral health center. And I think it's important that we do this to ensure the safest outcome for all of the patients that we serve. So we can't stop talking about COVID yet, but the question truly is it over? Is COVID over? And so if we look at just last week, 3/12, or a few weeks ago, and you looked at the new confirmed cases, almost 57,000, 7-day average was much less, which is a great marker of 35,000. But then if you look at 1 week later, new confirmed cases of a little bit less than 10,000, and the 7-day average is 8,000. For those of you who have followed this webinar series over the last 3 years, and I think it's absolutely remarkable that I've had this opportunity to share information with you over a 3-year period of time. You can see there was a period of time where there were over 200,000 cases in a day, or 200,000 cases in a week, and hospitals were full. Remember, we tend to forget things, and I don't exactly know why. Maybe it's because I work in a hospital, but at the beginning of this pandemic, when we had the original strain and then the alpha strain, there was a call for respirators. Where are the respirators? Because the alpha version was so bad, it was not just an upper respiratory infection, it was going into the lower lungs. It was causing pneumonia. It was causing all sorts of systemic failures that were happening, which is why we lost so many people. So many people were hospitalized at this time. Now we have the most contagious strain that we've ever had to deal with, but it also is less likely to be a serious disease that will put you in the hospital. So just giving you some idea of where we've been and where we're at now, and why we don't have to get a booster all the time. And actually, if you look at the booster data, if you had your 2 complete series to start with, and you're healthy, and then your chances of hospitalization really dropped quite low. If you got a booster, it even dropped lower. If you had the infection and got the 2 shots later on, you actually were pretty protected and you were covered. And we did talk a little bit about natural immunity last month. So literally, we're dealing with a different kind of infection today. Community transmission is really what guides us as dental healthcare providers on what safety efforts we should take or we should consider. If you look at the Southeast, which is usually where the worst outcomes and the most infections and everything occurs, we're clean right now. It's truly remarkable. But if you look at Nebraska, they're having a bit of an issue. And so it just depends on which part of the country you're in, but it almost is completely green. And that means the community transmission level is low. I just went to the Hinman Dental Conference. It's a big conference in Atlanta. There were maybe 1% of the people who were masked, and those people were those who considered themselves at risk. So they would be older individuals. They would be immunocompromised individuals. And there were some people whose family had been impacted. I am never going to say anything for those people who are getting ready to be my age and older. When you're in a crowd, you really should mask. And I think that's just common sense. There's cold viruses, there's flu viruses, there's RSV, there's COVID, and we'll cover all of those in a minute. And actually right now, everything does look good, but we want our older people who were hit so hard at the beginning of this pandemic, and children who also had issues, and we lost a couple kids recently. We just need to take the precautions necessary to make sure that we all stay safe and that we keep our families healthy. So Grady's policy, this is a hospital that has allowed me to be here for almost 30 years at this point. Effective on March 15th, masks are no longer required unless providing care for a patient in isolation. With the impending lift of the COVID public health emergency, and from all we have learned, we feel confident that this is the right move for our institution. Grady is the safety net hospital for Atlanta. Right now, it is the only level 1 trauma center in Atlanta. And while we have learned a lot over the past 3 years and have faced numerous challenges, from every challenge comes an opportunity for growth and change. We're really happy to take this step, but it's not to say that we're completely out of the woods. And I'm going to talk about that in a moment. But ensuring safety is our top priority, so we may require universal masking for employees and visitors again if our area's COVID-19 transmission levels increase in the future. And we want to stress that if you feel more comfortable continuing to mask, please do so. We acknowledge and support the fact that this is a personal choice. From now, this means patients, visitors, employees are no longer required to wear masks while on Grady campus and our offsite locations, such as the one that I work in, the Ponce de Leon Center. Masks are still required for all patients, visitors, and employees at Crestview. Crestview is the largest nursing home in the state. And so we definitely want to take care of those who are most vulnerable. For employees caring for patients suspected or confirmed to have COVID-19, and for anyone who is symptomatic or has close contact to or exposure to someone with COVID-19, and of course, masks are required for all isolation patients as appropriate. We have come a long way in knowing how to handle this virus, and we're pleased to make this change and get back to some sense of normalcy around Grady. We know this is a step our community and our employees have been looking forward to for quite some time. In addition to masks not being required, visitation policies have been updated at Grady to encourage family at bedside. We know having family helps in healing, both physically and emotionally. Please ensure you're familiar with the updated visitation and contact your leader with questions. So I think that was a big change. A lot of our meetings that were virtual meetings are now in person, and my medical executive committee is a meeting that is not masked. However, the Oral Health Center, the program that I run, is going to maintain all chair-side precautions due to the amount of aerosol we produce and the proximity between patients and providers, not to mention the length of time. Masks are no longer required for patients in the waiting room, but again, if it's the individual's personal choice, it's their decision. Community transmission rates of COVID will guide our protocols. Regretfully, one of my residents has tested positive, and we do believe her colleagues that she was with did not test positive, so we don't know if it was at the Hinman. It definitely wasn't in the dental clinic. So when I say that all chairside precautions, we're still going to use the extra-oral evacuation systems because our shields stay clean, the air is better here than in my home. We're still going to have the HEPA filtration units. We're going to take patient and provider safety as seriously as possible. So that is not going to change. But if you're in the doctor team meeting, or if you're in the staff group room, masks are not required. If you're walking through the clinical spaces of the program, masks are required. So I am not letting the guard down yet. I am not letting my staff become vulnerable to this pandemic, even though our numbers are remarkably low. It only takes one. And so therefore, we're going to maintain the safety precautions. So is the risk of long COVID different in the Omicron era compared to in the beginning parts of the pandemic that I was originally talking about? In a study that is soon to be presented at the European Congress of Clinical Microbiology and Infectious Diseases next month, researchers report that people who tested positive during Omicron were no more likely to report lingering symptoms after recovery than people who had never had COVID-19. In other words, we're not seeing nearly as much long COVID in this batch of patients, those who have been, and this has been going on, Omicron's been going on now since 2021, the end of 21. By contrast, those who were infected with the original SARS-CoV-2 variant were up to 67% more likely to report lingering symptoms than those who did not have COVID-19. I personally know people who have been basically crippled by this pandemic, and they did have the infection early on. People who were some of the most energetic advocates that I have dealt with on a national level are now leaving the fight against long COVID and making sure the research continues, that we look at treatments, and we are finding that certain treatments are helpful. Even a relatively old diabetic medicine seems to prevent it. Getting on the medications like Paxlovid, which has been recommended for normal approval, will help you avoid long COVID. So there's several things in this battle. We're not going to talk about that much on long COVID, other than it does seem that the risk of long COVID is reduced with the Omicron variant. Among Omicron cases of 56,000 people who experienced long COVID, and amongst Delta cases of 41,300 people experienced long COVID. So you can see that Omicron was 4.5%, Delta cases were double that, at least double that, at almost 11%. Omicron cases were less likely to experience long COVID for all vaccine timings, with an odds ratio ranging from 0.24 to 0.50. These results were also confirmed when the analysis was stratified by age group. So there's some pretty good data that we have showing this. So that's what I'm going to talk about COVID specifically today, because we are at such a different point, and we've changed the title of this webinar series to health issues. But COVID is not the only respiratory virus that we see. As we all know, there's been COVID-19, there's influenza, there's RSV amongst children and adults. It does look like a vaccine for RSV is progressing quite nicely along, and maybe we can prevent that. But there is a respiratory virus hospitalization surveillance network that comprises 3 platforms to conduct population-based surveillance for laboratory-confirmed hospital association with those 3 agents. While this doesn't cover every possible type of respiratory illness, and as I record this today, it is National or World TB Awareness Day, it does describe hospitalizations by 3 viruses that account for a large portion of hospitalizations. Surveillance is conducted through a network of acute care hospitals in select counties in 13 states. The surveillance platforms for COVID-19, influenza, and RSV, known as COVIDNet, FluServeNet, and RSVNet, cover more than 29 million people and include an estimated about 10% of the US population. The link at the bottom of this presentation is from the CDC, and that's where you can find the data in your community and where we are. If you look at it on the national perspective, it's pretty easy to see that we're on a downward trend for all three of these respiratory viruses. And then when you combine them, you can look at the numbers yourself. So during December, late November, we really reached a peak at about 20 people per 100,000 population were hospitalized due to any of these agents. You can see that COVID-19 is continuing to go down with a trajectory that is really heading in the right direction, less than 5%. If you look at the number of RSV and flu hospitalizations, they barely are showing up at this point. And so the whole total number of hospitalizations due to these three continues to decrease. What we are seeing, at least in my part of the world, is people coughing and wheezing and because of tree pollen. So we are going to have pollen. We still need to have a COVID test. There is a COVID flu test, but as you can see, flu activity is very low right now. COVID activity is heading down. RSV is heading down as well, very, very low. So what about the association between periodontal diseases and cardiovascular disease, diabetes, and respiratory diseases? There is a consensus report of the joint workshop by the European Federation of Periodontology and the European arm of the World Organization of Family Doctors. What they were looking at is to explore implication for dentists and dental healthcare workers and family doctors of the association between periodontal and systemic diseases and the role that we can play and family doctors can play in managing non-communicable diseases and promoting healthy lifestyles. So the findings: periodontitis is independently associated with cardiovascular disease, we know that. With diabetes, we know that. With COPD, again, we know that. Obstructive sleep apnea and COVID-19 complications. Dental healthcare workers, and I'm changing the language because we are a team. We have dental hygienists, we have dental assistants, dental therapies, we have dentists. And family doctors, including advanced practice providers in the United States, should collaborate in managing non-communicable disease, implementing strategies for early detection of periodontitis in primary care centers, and of cardiovascular disease and diabetes in dental settings. We actually can, if you're CLIA waived during your facility, look at hemoglobin A1C, and that'll let you know where somebody is on the diabetes curve. Family doctors should be informed about periodontal disease and their consequences, and our colleagues, the oral health professionals, should be informed about the relevance of these non-communicable diseases and associated risk factors. So we need to up our game. Our primary care colleagues need to up their game. And when we work together, the person or people that benefit are those we serve. That helps our patients make sure they have healthy outcomes, and it's a team effort. The mouth is connected to the rest of the body. The conclusion: closer collaboration between oral health professionals and family doctors is important in the early detection and management of these non-communicable diseases and in promoting healthy lifestyles. Pathways for early case detection of periodontitis in family medicine practice and of non-communicable diseases, in dental practice should be developed and evaluated. So that is something that we work on here because there's such great relationship between our advanced practice providers, our infectious disease providers, our oncologists, and the entire dental team. We are a family. So when we look at risk assessment, we have been doing risk assessment for caries, for periodontal disease, for all sorts of dental related things through the American Dental Association forms and different organizations forms for years. This is actually nothing new for us, but it's always been focused just on the provision of dental care and the person's risk of developing caries or the individual's risk of developing periodontal disease. How about we take it to the next level and look at risk when we're providing services for our patients? So there's different kinds of risk stratification that you can look at. There's the ASA physical status that I know is taught in every dental education facility these days, whether it's dental hygiene schools or dental school. ASA 1 is a healthy patient without organic, biochemical, or psychiatric disease. ASA 2 is a patient with mild systemic disease, no significant impact on daily activity, unlikely to impact on anesthesia and surgery. This is usually used by anesthesiologists, and I'm going to tell you a story in a moment. ASA 3, significant or severe systemic disease that limits normal activity, significant impact on daily activity, likely impact on anesthesia and surgery. So I've had some issues with my back. I've been very open about it. At one point, I had a hard time walking, found this new wonderful neurosurgeon, and to show what he thought was the problem, I was scheduled for an SI joint injection. So I'm on the table in the anesthesiologist's office, and I'm already hooked up to the IV. And he says, he's starting to dictate his notes, and he said that I'm ASA 3. And I look back at him and I said, I'm not ASA 3, I'm ASA 2. I don't have any mild systemic disease. There are some structural issues that are going on. The only thing I actually have is some hypertension. I argued one more time. He said, okay, we're going to put him at ASA 2. And that's the last thing I remember because he put me down, knocked me out. But I think it's a good story to say, just to give you an idea of how important these levels are and maybe a little humor. Things that we would not see in the dental sitting on a regular basis. A severe disease that is a constant threat to life requires intensive therapy, serious limitation of daily activities. These cases may need to be seen in the hospital. And as far as ASA 5 and 6, we don't see these patients at all. I mean, there's really not much we can do. If it's ASA 5, we may be able to do something for oral comfort, but that's about it. So I did want to go over what this risk stratification was, so give you an idea. And then there's another way of looking at it, which is risk equals the medical disease or diseases times the stress of the surgical procedure. Most dental procedures are considered low stress, including minor oral surgery. Major oral surgery can be considered as intermediate risk, and this is jaw resection, dealing with osteonecrosis on somebody who has osteopenia, or any kind of major thing. It's an intermediate risk. Risk stratifications includes medical diseases, functional status, maybe they were worried about my functional status, history, systems involved, which systems and how many, and then consultation and communication. Do we ask for clearance or do we ask for risk assessment? Traditionally, dentists and dental healthcare workers have asked for clearance. Most medical professionals only know what their dental experience is based on their personal experience or their family's experience. They don't know what we do. My best friend in college who went to medical school always told me that physicians and specialists were good from the chin down and from the eyes up and nose up, but when it came to the mouth, that was left to the dentists and dental healthcare workers, and that's basically true. So asking for clearance does not protect you, and it does not protect the medical provider that you got the clearance from. Communication is more important than just asking for clearance. So do we ask for a risk assessment? We're going to be doing 7 fillings on Mr. Jones. He has a history of some minor heart disease. What is your risk assessment for these procedures? I will be giving 2 carpules of lidocaine with 1/100 epinephrine. And then they can give you an answer because they're more specific. And again, you need to document what information that you do receive. But just getting clearance doesn't protect us. And I think that's the biggest point. So here is a case that I'm borrowing from a very well-known and respected oral surgeon in town. Just heard the case at the Hinman Dental Conference. 65-year-old male, well known to the dentist. He calls the office to say he broke a part of a dental crown. So it was a crown on tooth number 3. Not the tooth, but a crown. no pain, patient is worked in as an emergency visit. If you worked them in for the emergency visit and there was a rough edge, okay, maybe you would smooth it, but the dentist decided to go ahead and take off the crown and create a new crown as an emergency appointment. The medical history of the patient was positive for coronary atherosclerotic heart disease and congestive heart failure. The medications that the patient was on was hydrochlorothiazide and Lasix. So, dentist begins the treatment. The patient immediately feels lightheaded, has difficulty breathing, he's diaphoretic, which is excessive sweating, often another sign of medical conditions that could be potentially dangerous without treatment, becomes unresponsive, calls 911, and a well-known and highly regarded oral surgeon, the one I was referring to, is in the same building and offers assistance. So what was the next steps? The oral surgeon's assessment, breathing, patient was breathing, but severe wheezing and gurgling. Started the patient on O2, started an IV, gave an inhaler. When the oral surgeon looked at the patient, and we need to look at the whole patient, there was severe pitting edema. Patient did not take Lasix that day. Dentist should have never started treatment. Dentist bought new underwear. That was actually a line that he had in there, because whenever you're in a situation like this, of course, fight or flight really comes into play. They did call 911 appropriately, but did they ask if the patient had taken his medications that day? So he was in severe congestive heart failure, had pulmonary edema. They went to the ER, immediately treated with IV Lasix, O2, and a vasodilator, and the patient survived. The key here is, though, looking at the patient's medications and updating it on every visit, and especially for someone who has a history of congestive heart failure, did you take your medications today? And you can actually ask to look at the foot and see if there is pitting edema, since that is a sign of congestive heart failure. So use a lot of the training that we got in school, that we keep up with our continuing education, and apply it. And that way we can avoid conditions in cases such as this. Was this truly an emergency? And in my mind, probably not. I think they could have, like I said, smoothed the crown off. They could have worked the patient in and then had a consult with the patient's cardiologist or internist to see what was going on. And with the consult, ask for clearance? No, risk stratification. A patient with a history as significant as this should have triggered communication between the teams. Medical teams and dental teams have got to start communicating better. If you're 21 years old, no medical history, everything is fine, you're not going to call up the individual's internist. If and men, for the most part, regretfully, don't really go to the doctor when they're younger, but still you can look, you can do certain testing, blood pressures, etc., to see, look at your whole patient. I think that's one of the biggest issues that we have. The dental team should ask if the patient has taken his medications the day of treatment. And that goes for anti-anxiety medications for anxious patients, that goes for psychiatric medications, for coronary medications, in our case for HIV medications. Communication between teams could have prevented this event. And that is so very important. So hypertension. Hypertension is remarkably common in the United States. And here's some questions that I wish this was interactive, that I could get answers to while we're chatting, but I will be online when this presentation shows on, at least the initial show when it debuts on Friday. Do you take blood pressure at every visit? Do you take it at baseline just to get an idea? Before surgery, before periodontal surgery, before placement of implants? So the key is, do you at least have a baseline blood pressure on your patients? We actually take blood pressure before surgery. We take blood pressure before placement of implants. And actually, our residents take blood pressure at every visit. And therefore, if we have a patient, and remember, we have white coat syndrome. People could take a look at us, or they're in pain, and the blood pressure can be elevated. So we can talk about some certain things to do to see what the true blood pressure is. but taking a blood pressure, at least on a baseline for every new patient, and before you do a surgical procedure is good common sense. And that is something that we do here. And we have actually had a lot of people who would be considered in hypertensive crisis. And therefore, we can communicate with their primary care provider through either the EMR, through a phone call, through going down and in person and talking to them and say, listen, our patient has a really high blood pressure, nothing to go to the ER about, but it is over 180, it is over 110, and we really need to get it managed better before we can do the procedures we need to do. Hypertension is a remarkably common condition, and it's one of those conditions that's affecting your speaker today. If you have high blood pressure, the force of blood pushing against the artery walls is consistently too high. The heart has to work harder to pump the blood, and you can end up things like aortic aneurysms, etc. The American College of Cardiology and the American Heart Association divide blood pressure into 4 general categories. Ideal is categorized as normal. So that is 120 over 80. Actually, sometimes it's even lower. Elevated blood pressure, the top number is 120 to 129. And the bottom number is not above 80. Regretfully, I'm not there. Stage 1 hypertension, the number ranges from 130 to 139, and the bottom number is between 80 and 89, and that is my normal level unless I'm in a hospital. Stage 2 hypertension, the top number is 140 or higher, or the bottom number is 90 or higher. So just giving you what the stages of hypertension are, if you have this chart, which many of us do in our offices, then you can document a patient presented with stage 1 hypertension. You have it documented in your record. Having hypertension puts you at risk for heart disease and stroke, which are the leading causes of death in the United States, even during the COVID outbreak. In 2020, more than 670,000 deaths in the United States had hypertension as a primary or contributing cause. Nearly half of the adults in the US, 47% or 116 million, have hypertension, defined as the systolic blood pressure greater than 130 and a diastolic blood pressure greater than 80, and are taking medications for hypertension. Only about 1 in 4 adults with hypertension have their condition under control. And that is key, because they have hypertension, they might say they're on medication. Take their blood pressure. Every patient that has hypertension is another person we take blood pressure on. About 34 million adults who are recommended to take medication may need it to be prescribed and to start taking it. Almost 2 out of 3 in this group, 19 million, have a blood pressure of greater than 140 over 90. High blood pressure costs the US about $131 billion each year, averaged over 12 years from 2003 to 2014. And I do have the source for these facts on this particular slide. So where is hypertension showing up the most? And again, once the Southeast does lead the way, I guess the area in Georgia that has the lower level might be the mountains. If you're ever in Georgia, you must visit the Georgia mountains. They're absolutely gorgeous. But look at the rates in Alabama and Mississippi, Louisiana, Oklahoma, parts of West Virginia and Virginia. I imagine the blood pressure in DC is pretty high as well. I'm amazed that California, I guess before these awful storms, actually has pretty good levels of hypertension. So that's actually encouraging. I'd like to see what it is today, because they've been in a very unusual weather pattern. So the American Dental Association guidelines: if less than 160 or over 100, no modification. Emergency dental care, no modification. And you can repeat the measurement. And I think this is something that's important. Things that can help lower blood pressure when you're in the dental office. Making sure that their legs are not crossed. That is one of the things, every time I sit to have my blood pressure, my legs are crossed. And so an assistant will say, Dr. Reznik, please uncross your legs. Have they voided recently? If they void, it does help to get the blood pressure down. So we want to repeat the measurement. You might want to use a different arm, and also make sure you have on the appropriate size cuff. One size cuff doesn't fit everybody. There are people that actually, not like me, have muscles, and depending on where you put it, you're going to need a larger cuff, or maybe some people who are just larger in general. So those are issues that we have. Greater than 160 over 110. So for emergency dental care, if confirmed systolic pressure is between 160 and 180, and the diastolic pressure is less than 110, where dental symptoms and pain contribute to hypertension, initiate emergency care with blood pressure monitoring every 10 to 15 minutes during the procedure. Also consider anxiety reduction techniques. So again, if you look at what is the highest level of blood pressure that you can treat a patient, it's 180 over 110 or below, according to and so that's for emergency care. And that's what we do here in the Oral Health Center. If lowered or with the written guidance from a physician, proceed. So you might want to get the physician's input. Again, communication is so remarkably important. If confirmed, no elective dental treatment, and the patient should seek consultation with the physician. So somebody is hypertensive, greater than 160 over 100, they haven't been diagnosed, they're not on medication, it's not just anxiety visiting the dentist. We need to have a conversation with the patient and follow up with the patient's primary care provider. How many of you list the primary care provider for your patients and the phone contact number? And this is important. You might not get the physician on the phone. You might get an advanced practice provider, a nurse practitioner, a nurse, or even a nurse practitioner and a physician assistant. They might be the people that call you back. It doesn't matter as long as you get the information and you go through the risk stratification. So what about the indications for pre-medication from the American Heart Association and the ADA? Well, in 2021, while I was talking about COVID on a regular basis, and we were all figuring out how we're going to get our PPE in and N95 fit testing and all those different things, there was a change in the guidelines. Not necessarily what I show you on this page. I mean, this has basically been the same for a few years at this point. But there has been a change on the recommendations for medications. So still, we recommend amoxicillin. If you have a penicillin or an ampicillin allergy, then there's possibility you can take Keflex, but there is a pretty broad cross reaction with Keflex. So then there is azithromycin, otherwise known as Zithromax, or clarithromycin, otherwise known as Biaxin, or doxycycline. So these are medications that are now the oral medications that are approved. There are IV medications that are approved as well. Most of us, unless you're doing conscious sedation or things of that sort, are not using IVs. So I think it's really key if you're looking at this and you can figure out which medication has been removed. So Zithromax or Biaxin or azithromycin or clarithromycin. Some people choose Biaxin, but it really depends on what's available. And doxycycline, again, it's 100 milligrams. So what medication is missing? And the medication is clindamycin. Clindamycin has been highly associated with C. difficile. It is very contagious, not in the dental setting, but it causes awful GI distress. It causes the runs. It's very hard to clear. When you have this, patients are actually placed in isolation because you literally need to do a terminal clean with bleach with the patient in the hospital. We don't expect to have any fecal matter in the dental setting, so that's not something that we deal with on a whole lot. But there are cases of dental healthcare workers putting patients in the hospital from writing clindamycin too much. And so there was one provider I know that after every oral surgery, I've written clindamycin my whole career. And then I had to show the person, well, maybe that is the case, but these two people are in the hospital based on that. And so we really need to be careful when we write clindamycin, and we really need to be careful about when we write antibiotics, because antibiotic stewardship is very, very important in the dental community because we write a significant number of antibiotics. One of my greatest concerns during COVID was the number of patients who are showing up to emergency departments for dental visits. They don't get the information that we get on a regular basis. And so there were a lot more antibiotics written than normal, most likely a lot more opioids that were written than normal by these emergency room docs. They would put them on antibiotics for swelling or for whatever. If you have an oral surgery department as good as the one we have at Grady, which goes through Emory, then we can address the situations more carefully, but we really need to be careful with what we write. So certain types of C. diff actually can be life-threatening. It is common. There's more than 200,000 cases per year in the US. We're literally trying to follow whether it's community-based C. diff that we're seeing in the hospital, or is it something in the hospital that they're getting as a nosocomial infection. It is treatable by medical profession. It requires lab testing and imaging, and it can last several weeks or months. So I remember one of the first times I had to go to the hospital to do an oral consult on a patient with C. diff. You would have thought I was dealing with Ebola. I mean, literally, that's how wrapped up they had me to go into that particular patient room. So it is one of the agents that we're worried about. An agent that I'll talking about some next month, Candida auris, which is, again, another life-threatening fungal infection that you might have heard about on the news. We'll talk about that. That, again, is a bloodstream infection that we're basically seeing in hospitals. It's not something we're seeing in the dental community. Let's not be a part of the problem. Let's be a part of the solution. So what about our old friend Mycobacterium abscessus? We know about the clusters that happened in dental unit water lines. There was one that happened in a suburb of Atlanta. There was one that happened in California, where I think there were 100 children that one way or another were impacted in both of these. There is actually a possible third outbreak in Georgia. And as a member of the Georgia board, I really am pushing us to address this in our continuing education. I know California has taken their own steps to address this, but we aren't the only place. So we know that it's something in dental unit water lines. We're taking dental unit water line safety very seriously in dentistry. We're testing our samples every month. We're shocking when need be. If that doesn't work, we're changing out the piping, the tubing, because the tubes are so small. And so that is a priority for the dental profession. But we really haven't heard much about this as an issue in the medical setting. So there's a new publication in the Annals of Internal Medicine, which was released this month, showing that M. abscessus is now an issue presenting in other settings, and in this case, a cluster in cardiac surgery patients due to a commercial water purification system. The background. Non-tuberculosis mycobacteria are water avid. They love water pathogens and are associated with nosocomial infections, meaning healthcare acquired infections. Objectives: to describe an analysis and mitigation of a cluster of Mycobacterium abscessus infections in cardiac surgery patients. The setting was at one of the best known hospitals in our country, Brigham and Women's Hospital in Boston. The participants were 4 cardiac surgery patients. The results: whole genome sequencing confirmed homology among clinical isolates. Patients were admitted during different periods to different rooms, but on the same floor. There were no common operating rooms, ventilators, heater cooler devices, or dialysis machines. Environmental cultures were notable for heavy mycobacterial growth in ice and water machines on the cluster unit, but little or no growth in ice and water machines in the hospital's other 2 inpatient towers, or in shower and sink faucets water in any of the hospital's 3 inpatient towers. Whole genome sequencing, as I said, confirmed the presence of a genetically identical element in ice and water machine and patient specimens. Investigation of the plumbing system revealed a commercial water purifier with charcoal filters and UV irradiation unit leading to the ice and water machines in the cluster tower, but not in the hospital's other inpatient towers. Chlorine was present at normal levels in municipal water source, but was undetectable downstream from the purification unit. There were no further cases after high-risk patients were switched to sterile and distilled water. Ice and water machine maintenance was intensified, and the commercial purification system was decommissioned. So, as always, I want to thank you for taking the time. It has been a remarkable honor to be able to present for 3 years on topics that impact dentistry from the health side. As always, I look forward to your questions or areas that we'd like to cover in the future. And I'm going to turn it over to a really great guy who I did have a little fun with today, and wish happy birthday, Dr. Severance. Thank you.
Thank you, Dr. Reznik, for the last 3 years and always providing information vital to the dental profession. And thank you for watching. Please subscribe to the YouTube channel by clicking the subscribe button below. And to be notified of any premieres, please click the bell icon. If you have any questions, concerns, or topics for future episodes, please email us at webinars@henryschein.com. Thank you once again for attending, and please stay safe and stay informed.